All right, I'm going to dive right into it. So I was asked to talk about our work in New York City to apply a status neutral framework in our work to end the HIV epidemic. And that's what I'm going to talk about today. I have no conflicts of interest, financial or otherwise, to disclose. And here's what I'll cover in my talk today. So I'll give a little bit of a background on HIV in New York City, what we're seeing now in terms of the epidemiology. I'll talk about the status neutral framework, and then I'll talk a bit about how we've applied that framework in New York City, share some lessons learned, orient the discussion and our work around the New York City 2020 Ending the Epidemic Plan, and then we'll have time for questions and answers. So in terms of the epi, where are we with HIV in New York City? So this is a busy graph, but it's one where we try to squish the entire story, at least told through data, of the city's epidemic onto one slide. So it's showing the history of our epidemic from 1981 through 2022. 2022 is at current, our latest full year of data published. So I'll just, orient you to a few moments which you all will be quite familiar with, I'm sure, just because they track nationally. But in the red line is the number of new AIDS diagnoses, which of course peaked in the mid-90s and then has declined precipitously since after the introduction of highly active antiretroviral therapy. The green line is the number of HIV-related deaths, so deaths actually attributed to HIV infection itself. In New York City, which follows a very similar shape to the new AIDS diagnosis line, with a peak in the mid-90s and then dropping quite precipitously since, as people initiated and adhered to treatment. And then this black line that starts in the middle of the graph is the annual number of new HIV diagnoses that we count in our surveillance system. In New York State, named HIV reporting by law took effect in mid-2000. So 2001 is our first full year of data available. So you can see each year we see a drop in new HIV diagnoses. The blue bars in the background represent the growing population of people living with HIV or AIDS in the city. Of course, as those numbers of diagnoses have increased over this 40-year trajectory, but also, of course, as people have lived and survived with HIV. So there's our epidemic in a nutshell. And then dialing in just to the most recent year of full data available, we had over 1,600 people newly diagnosed with HIV in the city. We had a little over 1,000 new AIDS diagnoses made by New York City providers. And then we had 1,603 deaths among people with HIV in the city. And those are deaths due to all causes, not just HIV. HIV-related deaths represent about 18% of our deaths annually. So one of the things we do with data from our surveillance system is not only track reported new diagnoses, because we get laboratory results for HIV tests and can identify if they belong to someone never before who tested positive and therefore representing a new diagnosis of HIV, but we also use our data and specifically an estimation method developed and promoted by the CDC to estimate HIV incidence, to try to get a sense of the sort of leading edge of HIV in the city, beyond what the picture of new diagnoses shows us. And I can tell you it's actually not very different from what the picture of new diagnoses shows us, insofar as the estimated annual HIV incidence, incident infections, the vast majority are among men who have sex with men, that orange line at the top, followed by heterosexual females, and then people with a history of injection drug use, and then heterosexual males. So this very much mirrors the sort of transmission risk breakdown of our new diagnoses as well in the city. So men who have sex with men, or MSM, bearing a heavy burden of HIV in the city. So also looking at now dialing back out to the number of new HIV diagnoses and looking at them by gender in New York City for the most recent 5-year period. I mean, again, you see men bearing most of our new diagnoses each year in the city, followed by women, and then transgender women and transgender men. Very small year-over-year numbers for trans men, but non-negligible numbers of new diagnoses for trans women. Um, you know, just as our new diagnoses are not distributed equitably by gender identity, they're also not distributed equitably by race and ethnicity. So we see very persistent racial and ethnic inequities in New York City in terms of our new diagnoses. So here you can see over this most recent 5-year period, but it would be the same if we looked further back. The vast majority of new diagnoses are among Black and Latinx individuals, followed quite a bit lower by white individuals, new diagnoses among white individuals, Asian Pacific Islanders, multiracial, and Native Americans. We also use data from our surveillance system, specifically HIV-related laboratory data, so CD4 counts, viral loads, genotype tests, to as a sort of proxy measure for whether and how much and on what sort of timeline people are receiving HIV-related care in the city. So one of the things we look at as an indicator is linkage to care within 30 days of diagnosis, which is sort of a standard, and then whether people are also achieving viral suppression within 3 months of diagnosis. So the purple line is the linkage to care indicator, and you can see basically 80% of newly diagnosed individuals are linked to HIV care within 30 days of diagnosis. It's pretty flat. And similarly flat, but lower, is the proportion virally suppressed within 3 months of diagnosis, which is hovering around 50%. We also generate an HIV care continuum each year to provide a snapshot of sort of the stages and extent of care engagement for all people with HIV in the jurisdiction. So we estimate that there are approximately 87,000 people with HIV in New York City in 2022. And you can see that we estimate 95% were diagnosed, 88% received care, 84% were prescribed ART, and then ultimately 80% were virally suppressed. Again, kind of to the point I made earlier, where we're really concerned about and persistently see these racial and ethnic inequities in the way HIV itself, in terms of new diagnoses and cases, but also in terms of outcomes, is distributed in New York City. So we also generate our HIV care continuum by race ethnic groups. And if I just even orient you to the bottom yellowish bars, you can see important disparities in the proportion of Black versus Latinx versus white and so on New Yorkers are virally suppressed. So for example, 76% of Black people with HIV virally suppressed in 2022, compared with 88% of white people with HIV. So, all of this, of course, suggests, and not newly so, that it is critical that we focus our efforts and resources on the communities and populations within New York City that are sort of historical, overall quite effective interventions and programs are not really reaching. So I think I think it's an important setup for some of the programming and framework, work that we've done in New York City that I'm going to be sharing with you. So let me talk now about the status neutral framework and how we conceive of this in New York City. So the status neutral framework. So, we think it's critical. And what it does is reframe this very traditional and kind of persistent divide between HIV care and prevention, and the very linear, as you could see from my previous slides, unidirectional approach of the traditional care continuum. So, right, the idea is, the moment of diagnosis, you are then, as an individual or as a population, marching through these moments in the care, marching through or not, these moments in the care continuum. But it's a very inflexible, non-dynamic rubric for what we know is a very complex experience for individuals and communities to be living with HIV or diagnosed with HIV or vulnerable to HIV, and then interacting with the healthcare system, which itself is complicated, around HIV-related needs. So instead, what we did was develop and publish this infographic, and we sort of put it out there in 2016. and then published it in the peer review literature in 2018, this much more dynamic sort of status neutral care continuum, which starts with this moment of an HIV test, and then there's a flow through these stages that are dynamic and can be circular, and can be revisited dependent on the results of that HIV test. So if the result is positive, there's a flow through this side of this cycle. And if the result of that test is negative, there's a flow through this side of the rubric. So right, as I mentioned, we first published this infographic in 2016. And right, so just to be clear about what I said, so if a test is positive, the idea is that then the person with diagnosed HIV is entering through this cycle related to HIV care services. So there's a diagnosis, then there's attempts at engagement in care and retention in care, ultimately the offer of treatment and initiation of that treatment, retention on treatment, and then viral suppression. And the idea is here too to emphasize the ongoing nature of treatment engagement, and also the expectation that treatment should be high quality. If the HIV test is negative, then of course, on the assumption that the person was testing because of vulnerability to HIV acquisition, that then there's still, and different though, engagement with the healthcare system. So that there is an emphasis on the need to make that discussion of an HIV negative test result part of a broader discussion about sexual health and wellness and services, to ensure that there's awareness of PrEP, to review the benefits of PrEP from a provider with that patient or client, and then have that discussion of PrEP be with someone who can prescribe if there's an interest in the person taking PrEP, and that there's then sort of cyclical, even once someone is on PrEP, or if they don't initiate PrEP at that moment, that there's then flow back through and revisiting of these steps of engagement in prevention care and services, and that HIV and STI testing, frequent testing and offer of testing, is part of that engagement. And let's see, what else did I want to say about this? And so, again, I think there's just to say also in the background of this infographic is there's, the idea here is that that individuals will move through this status neutral care continuum, but that it really is about a community, a population, in this case, New Yorkers, flowing through so that their sexual health and outcomes and health are optimized throughout. And at the end, the idea is that there's not only an individual benefit either of achieving viral suppression or of being on PrEP to prevent HIV infection, but that there's also population level benefit and public health benefits, such that people then at risk of HIV exposure are taking daily PrEP or PrEP on demand. This is outdated in that sense, or that people with diagnosed HIV have sustained viral load suppression, and that all groups have a negligible risk of acquiring or transmitting HIV. And so it's a community impact that will contribute to ending the HIV epidemic and optimizing outcomes for everyone. So I mentioned a couple of these points, but this status neutral framework really emphasizes an integration of HIV care and prevention services, integration of both into primary care and other services. I think, it's interesting, putting together this presentation, it's interesting to reflect on, how far or just how much advanced some of our discussions have even come since 2016, which is now a while ago, where we're talking about, syndemics, right? We're talking about co-occurring, not just HIV, but sexual health, STIs, drug user health, viral hepatitis, these other things. So I think this first bullet could really even be broadened to say, like, the integration of HIV care and prevention services with STI care and services, sexual health services, viral hepatitis, et cetera. But I think, presciently, if I may, it also emphasizes that there are common drivers a vulnerability to HIV acquisition and poor outcomes after HIV acquisition. Again, a sort of foundational conceptualization of this syndemic approach that is now really being promoted is that these co-occurring sort of poor health conditions are driven by a common set of factors. The status neutral framework also really emphasizes the need to ongoingly assess and address social determinants of health. It promotes the benefits of a person-centered approach to care and service delivery, such that it's really about, a person's engagement with the healthcare system is about their needs at any one time. And those needs can be dynamic, they can build, they can change, and that it emphasizes to more active and longitudinal engagement by providers in patient well-being. It also emphasizes destigmatization of HIV, which is, of course, critical. We know that stigma absolutely very proximately contributes to poor HIV-related outcomes. It also enables then sharing and leveraging of resources and expertise across, these previously very siloed prevention care sort of channels. This focus on syndemic or co-occurring conditions, the opportunity to address the holistic needs of priority populations. It certainly enables and kind of encourages more efficient service delivery, such that if I were a provider and I have a patient in front of me, I'm addressing their multiple needs, not just, just their needs as an HIV positive person, but what else is happening. It also enables improved health equity, given the intersection of HIV stigma and other biases. And then ultimately, for sure, it's part and parcel to success of our efforts to end the HIV epidemic. So the National HIV/AIDS Strategy, the current one in effect for 2022 to 2025, which was released in December of 2021, it incorporated a status neutral approach. So here's the sort of box 5, very much kind of building on New York City's, infographic and framework to kind of codify, so to speak, the status neutral approach as a best practice of the National HIV/AIDS Strategy for all jurisdictions. And just to look closely at it, it very much mirrors our original status neutral framework, but it does make, I think importantly, even more explicit the role of supportive services in keeping both people who test HIV negative and people who test HIV positive healthy and well. And so I think, this really, more than New York City's own infographic, when this was published a few years later, I guess 5 years later, it really sets the stage for considering this syndemic approach that we are now, much more steeped into. And strategy 1.2.3 is the strategy in the NHAS that actually calls out the status neutral approach to HIV testing, right? Such that that HIV test is determinative in terms of what a person then, how they will or could engage with the healthcare system. So how have we applied this status neutral framework to our efforts in New York City to end the HIV epidemic? So there are 3 primary areas where we've adopted this status neutral framework. We've applied it to social marketing over the last few years. We rebranded our city STD clinics, and we've enhanced some of our contracted services. So I'll explain each of these briefly in the following slides. So first, about our efforts at producing and promoting more status neutral social marketing. So here are some images from our PlaySure campaign, which was launched in 2015. It expanded on an earlier campaign, our 2014 Be Sure campaign, which really had just a prevention focus. And the primary call to action for this social marketing campaign was around HIV testing. So PlaySure, launched in 2015, as I mentioned, really was explicitly sex positive, and it took a combination prevention focus. So it talked about PrEP, HIV treatment, and condoms. So really embodying this, we're not just going to talk about sort of people vulnerable to HIV, but also people with HIV. It was launched then our next iteration of this, Stay Sure. So sorry, the middle image is PlaySure. And then the two side images are from our subsequent campaign launched in late 2016, early 2017, which was about staying sure. And it really promoted HIV treatment as prevention. Here are some more images from both Play Sure and Stay Sure. So again, this kind of integrated messaging across the HIV kind of continuum. We also just recently, in another sort of effort to embody this status neutral framework, we also just updated that Be HIV Sure message campaign that I mentioned back from 2014, which had really kind of singularly focused on HIV testing. We just updated it, and it's posted on our website, and we have printed materials available for order by our partners and stakeholders in the city. But it really, emphasizes HIV testing, but also other prevention and care services. The information provided to consumers who text the number here or go to our website really cuts across prevention and care service landscape. So that's exciting. That just happened. We also had our Summer of Sexual Health marketing campaign that was launched last year, where again, as you can see, it's a little bit small, but you can see at the bottom of the slide here, the sort of services and information that are highlighted really cut across. So it's STI prevention, testing and care, LGBTQIA plus health, HIV prevention, testing and care, reproductive health, and other health-related information and resources. So that ran throughout the city last year. Another way we've really embodied the status neutral framework or applied it in New York City is through the rebranding of what had been known as the city's STD clinics as sexual health clinics. So in spring 2015, the health department had announced the closure of one of our kind of well, they're all important, but one of our most visited and frequented STD clinics, our Chelsea STD clinic, is one of 9 STD clinics that were offering low to no cost STI and HIV testing and treatment. And these data show you that it was really, it is a clinic that had a really important impact on HIV and STI prevention and treatment and care in the city. So at the time, 1 in 42 MSM attending STD clinics were diagnosed with HIV within a year. 1 in 15 MSM and 1 in 7 Black MSM was diagnosed with anorectal chlamydia and or gonorrhea in the STD clinics. Who was diagnosed with one of those conditions were diagnosed with HIV within a year. And 1 in 20 MSM diagnosed with primary or secondary syphilis in New York City were diagnosed with HIV within a year. So really seeing a highly vulnerable population who was in need of services. Following this announcement, which was due to a fiscal crisis, ACT UP New York, Treatment Action Group, other activists really organized a very strong response to the clinic closure. And they mobilized membership of their groups and other community members and activists to protest outside the clinic and City Hall. Here's some images from that. So there was a widespread media coverage of this, and advocacy really made a difference. And in February of 2017, our commissioner at the time, Dr. Mary Bassett, in fact, announced funding to expand and enhance all of the STD clinics, which included specifically a $26.3 million overhaul of the Chelsea STD clinics. So this was at the time when the city and state had just come up with our statewide ending the epidemic kind of blueprint and associated plans. And so, this effort to rebrand the STD clinics into the sexual health clinics was part of where do we go from here? How do we deepen our engagement and make it more resonant with community needs around EHE? So in March 2018, the clinic opened as the Chelsea Sexual Health Clinic, and it really changed its service model. So there were expanded hours. It's a beautiful clinic. It was extensively renovated. There are state-of-the-art service enhancements, and all of this was funded by city dollars. As of March of this year, 6 of the sexual health clinics are open these days. Here's our website. There's a map with locations. We are still working to sort of reopen services that had been either closed or repurposed for COVID-related work during the height of the pandemic. But the sexual health clinic services are really wide-ranging, and they're very much, from a status neutral standpoint, offering these STI services. There are vaccination services. There are HIV services, so not only HIV testing or even PrEP, but actual treatment initiation for HIV, which we call our Jumpstart program, patient navigation to HIV providers, of course, emergency PEP and PrEP, but also behavioral health services that we know are really important for these affected populations and that support HIV and sexual health service seeking and success. There's also a range of reproductive health services now at the clinics. Really exciting. We have medical abortion services that were launched, I think last year, was it last year in the wake of the Dobbs decision, at a few of our clinics that have been really well received and well utilized. Here are some fun images from a campaign that we launched to promote the rebranding of the sexual health clinics. It was super fun and, kind of racy and attention drawing, and really, I think, did a lot to, I think, rebrand the health department even, right? To get us in this mode of that we are a viable provider of services, affirming services, responsive services to, community and whole person needs. And the last thing, we did was, or the last thing I'll mention as an example of the ways in which we've applied a status neutral framework is to enhance some of our contracted services, specifically our Ryan White medical case management services. So Ryan White funded facilities in New York City use a medical home model, which really is designed to and does offer comprehensive patient-centered care for people with HIV. And so this concept of the medical home, it's a medical, a multidisciplinary approach where case management, care, and support services are all integrated, and patient-provider relationships are really emphasized. For years, that has existed and been very much focused on just people living with HIV and their needs. So the shift to build in a status-neutral care coordination kind of aspect to the Ryan White programming is to then we built a sort of corollary set of services for people not living with HIV but vulnerable to HIV. So people who tested negative. So the goals, though, are very similar in terms of this integration of services, this whole person approach, this emphasis on the provider-patient relationship, and it was, quite a seismic shift in framework, especially for something like Ryan White and the HRSA program that supports Ryan White, to then develop this, complementary set of services and programming for people who are HIV negative. I will note that that status neutral care coordination program ended in 2022 because of new funding and a new program that we launched, which I'll talk about, whereby we encouraged those contracted providers who were providing the status neutral care coordination to instead apply for this new source of funding to kind of continue the same approach that they were doing, but just under a different program. Another thing I'll share is the Playshore Network. The Playshore Network was launched, I believe, in 2017, and it really was focused on HIV prevention. And there's a citywide network of HIV testing sites, both clinical sites, community-based organizations, and the goal was to really have these sites form a network to work together and with partnership from the health department to promote, patient-specific approaches to sexual health and HIV prevention. Sort of required or promoted activities were things like offering PrEP, emergency PEP, linking people who test positive to HIV care. That was launched in 2017 and it ran through 2021. And then when that program ended in March of 2022, preceding March of 2022, we really did some more thinking about this Playshore Network model and how we might essentially, broaden it and give it an even more explicit status neutral approach. So in 2022, we launched the Playshore Network 2.0. And this was, again, a citywide network of agencies, this time 18, who were funded by us to provide a comprehensive package of HIV-related services, and really promoting this one-stop shop model. So HIV testing, PrEP and PEP, IART, so for people who test positive, and linkage to HIV primary care and actual primary care delivery for those clinical institutions involved, STI testing and treatment, and then also outreach, navigation services, linkage services, and then a range of supportive services, mental health, substance use, behavioral services. So, PSN 2, we call it PSN 2.0, really embodies the status neutral approach, I think, even to a greater degree. And it's been, it's really been successful so far. So in the first year of the network, these 18 agencies had over 3,800 client enrollments. Most of them were received an HIV test. There were nearly 8,400 STI tests given. And we do a lot to kind of evaluate the model as we go, both from the client perspective and the implementing agency perspective. And, one of the goals is to get providers to be more interactive and sort of responsible for having sexual health and need related discussions with their patients. And so it seems like that's happening most of the time. Another sort of emphasis of the program is to get agencies to make organizational changes that are going to support their ability to promote and deliver services in this status neutral, one-stop shop, integrated kind of model. And so that is happening. So, those are some examples of the ways in which we have applied a status neutral approach through our programming. And I think we've learned a lot. I think the benefits of a status neutral approach are numerous and pretty clear. I think, a huge one is just this reduced institutionalized, internalized, also stigma for people with HIV. I think that's really important, such that literally co-locating these services for both people with HIV and people vulnerable to HIV in the same place itself is a strategy for destigmatizing HIV. I think it also creates efficiencies such that the same providers are trained to provide a range of services based on specific client needs. It improves resource utilization, right? We can share across these previously very siloed prevention care funding sources. I think we do a lot to embed community feedback and engagement, results of community engagement in our work. And I think the status neutral approach allows us to gain and share insights from programs, both serving people with HIV and programs serving people who test negative, into programming that addresses both. And then again, I've been emphasizing this, but I think it really enables our programs to become more person-focused, and to tailor service delivery to individual needs. That person-focused approach, I think it has allowed us to assess our models of care through a new lens. It really is about, promoting self-actualization, well-being, by really normalizing and making more frequent and affirming conversations and strategies to optimize individual and community health. We also, we've made sure that the status neutral approach to HIV is a sex positive one. So it focuses also on sexual health and pleasure, as well as harm reduction. And ultimately, there's a lot of respect for the individual and their autonomy in their health seeking as part of the model. I will say, some of the other lessons learned are that it really requires a thorough, deliberate approach. I mean, it doesn't, because there is such historical siloing of HIV prevention and care, it requires an intentional sort of integration of the two. So robust collaboration is critical, both within a health department, as implementers of the status neutral approach, but also with our external partners and systems. There's a need to align messaging, programming, and to be creative in the use of multiple sources of funding, because funding, especially from the federal government, is quite prescriptive, and it may be necessary to blend funding so that the totality of a status neutral, for example, program, the totality of its needs can be met through maybe multiple sources. I'll just mention our New York City 2020 Ending the HIV Epidemic Plan, which in and of itself has very much a status neutral sort of framework. So in March of 2021, we released this plan. It builds on what I mentioned was an earlier release from 2014-15, the New York State Blueprint for Ending the Epidemic, and then there was a corresponding New York City Ending the Epidemic Plan. But this 2020 EHE plan, as we call it, is organized around 4 EHE strategies that also mirror those at the federal level. So to diagnose, treat, prevent, and respond to HIV. And we, in our New York City plan, embedded these two kind of, I'm never quite sure what to call them, but threads or foci, the social and structural determinants of HIV-related health inequities, and the HIV service delivery system. The idea being that all of our work to meet the goals and needs of those EHE 4 pillars should be considering social and structural determinants of health and inequities, and also seek to extend our work and the change making to the HIV service delivery system. So our plan names a number of populations that we say, we just have decided based on the epi of HIV in New York City, that these populations are those that sort of need and require additional focus, additional resources, so that EHE goals can be met among them as well. So Black MSM, Latino MSM, Black women, Latino women, all people of trans experience, and people who identify as gender nonconforming, non-binary, or genderqueer, people ages with HIV ages 50 and older, and then youth and young adults ages 13 to 29. We also, in the plan, we named these additional populations that we know have particular vulnerability to HIV or to poor outcomes after being diagnosed with HIV. So people experiencing housing instability, people with serious mental illness, people who use drugs, etc. So these are other populations that we are ensuring our programming and resources are intentionally designed to support. And here are just a few examples. The plan has strategies, and then within each there are key activities. And so there are a number of key activities and strategies that really explicitly employ a status neutral framework. So, for example, key activity 1 is around ending stigma and discrimination, and activity 1G promotes the status neutral healthcare model through providing these various things. Key activity 2 is around the promotion of multi-sectoral collaborations and partnerships, and then names status neutral policies and efforts as a key sort of channel through which to promote those kinds of collaborations and partnerships. Key activity number 6, for example, is about adopting a status neutral approach to promoting the well-being of people with HIV, and calling out that status neutral programming and interventions should be incentivized, and that they should also be used to expand access to behavioral health services. So just to say that the plan that is currently guiding our efforts to address HIV in New York City very much names and promotes a status neutral approach because of the many ways in which we've found it to be not only impactful, but also, and I don't mean to be sort of casual, but it just makes sense. I think we know that people, especially populations and people who are harder to reach with our traditional services, they need a different approach. They need a whole person, dynamic, well-supported approach to meeting their HIV and sexual healthcare needs. And so the status neutral approach, I think, is one that we find to just really make a lot of sense. I will end there, and I'm happy to take any questions or hear thoughts, discussions. I'll just show my contact information. People are welcome to contact me at any time with follow-up thoughts or questions about our work in New York City. Thank you so much.